Good morning to everyone joining the Grand Rounds Zoom presentation. We're just going to wait a couple of minutes to allow everyone to enter the room and we'll get started. Okay, good morning to everyone who has joined our combined Mass General Brigham Global Health Grand Rounds. We are excited to welcome all of you, and I see more people joining the call. I have the honor to introduce our speaker. Dr. Oyere Onuma is the founding director of the Mass General Hospital Global Cardiovascular Health Program. She earned her medical degree at the Yale School of Medicine and completed her residency and fellowship at Massachusetts General Hospital. She also earned a master's in science from the Harvard T.H. Chan School of Public Health in 2014. She has served as the medical officer for cardiovascular disease management at the level of the WHO and has previously served as the associate director of the Yale Preventive Cardiovascular Health Program. We are very lucky that she joined the faculty at MGH and Harvard Medical School in 2023. Dr. Onuma is the author of multiple publications on global health and cardiovascular disease prevention in leading medical journals. We are so delighted that she'll be speaking us today on this topic related to global cardiovascular health. So Dr. Onuma, welcome. We're excited to have you.
Amir, thank you so much for that kind introduction, and really big thanks to the Global Health Group for having me today. I'm really quite excited to be here, and apologies for my voice. I'm just getting over a head cold. So I'll just go ahead and and share my screen so I can pull my slides up. Let's see. I tried this earlier, so hopefully it works out well. All right, brilliant. So today, what I'm hoping to do in the next half hour to 40 minutes is really sort of address a sliver of global cardiovascular health. And the lens that I've chosen to look at it from today is looking at the transition from innovation to implementation really as the key modality for addressing the epidemic of global cardiovascular disease. What I hope that we will gain at the end of this time together is a better understanding of the gaps in cardiovascular disease incidence and outcomes, particularly in low and middle income countries, to an understanding of some, not all, some key innovative strategies and technologies that can be leveraged to achieve global cardiovascular health equity. And then 3, in talking about implementation, I thought that it was better to talk about implementation using an actual case study, and we'll be addressing some of our work in cardiovascular disease management in Cabo Verde. So just to start off, this September, in September of 2025, the UN General Assembly, obviously operating on the premise that the UN still does exist in September of 2025, will host a 5th high-level meeting on non-communicable diseases, including cardiovascular disease. They will consider at that meeting the progress on the global action plan and progress in the control of non-communicable diseases, including cardiovascular disease, since 2018 and more distantly since the very first meeting in 2011. Why is this something that is of importance at the level of the UN and something that warrants all of this global action and all of these global meetings? This is just a quick look at what the global burden of cardiovascular disease looks like. And just to orient you, we don't have to go into all the numbers. red is really bad, blue is very good. So if you take just a quick look at this heat map, then you see that a significant amount of the burden still lies in Central Europe, in Asia, in Southeast Asia, and actually an increasing burden in Sub-Saharan Africa, with age standardized disability adjusted life years anywhere from 8,700 to 20,000, as compared to 1,300 when you look at a number of the countries, including the United States, who are in the blue. When you look at the global ranking of cardiovascular deaths by actual cause, number one in terms of death still remains ischemic heart disease, followed by ischemic stroke and intercerebral hemorrhage, usually quite closely linked to hypertension. But 4 and 5 are interesting because these are not things that we often consider, particularly in our practice here in the United States, which is hypertensive heart disease, and coming in at number 5, rheumatic heart disease. So this is something that I will refer to again, but it is instructive, to understand, to try to break down those global cardiovascular deaths by cause. So we know what the situation looks like, approximately now. If you think then about what the projections for global cardiovascular disease look like, looking into 2050, then what we actually see is a significant increase in the total number of cardiovascular deaths by 2050. So now, or as of 2018, there were about 20 million cardiovascular deaths, and that is projected to increase to 35.6 million deaths by 2050. It's not all completely bad news. Actually, the age standardized cardiovascular mortality is trending down, and that's the red line that you see there. So that's somewhat good news, but that trend down in age standardized cardiovascular mortality rates is overshadowed by the increases in population numbers, which overall lead to an increase in cardiovascular deaths. More so, these changes in the age standardized mortality rates are not uniform when you look across the world. So in high income countries like ours, that change is almost 50%. While if you look in Sub-Saharan Africa or Southeast Asia, that change is very modest and somewhere on the order of 13 to 16%. And obviously it is instructive to note that these are areas of the world with some of the largest populations, and hence areas that will see the biggest burden of cardiovascular deaths by 2050, particularly if things are not different. So just in summary, cardiovascular diseases, have the ignoble distinction of representing the leading cause of death globally. Again, from those 20.5 million deaths worldwide now, forecasted to almost double by 2050. The largest burden of these deaths, and usually mostly premature, meaning occurring before age 70, are happening in low and middle income countries. As I showed you, ischemic heart disease and strokes, both ischemic and hemorrhagic strokes, are number 1 and 2 causes of death, respectively, but hypertensive heart disease and rheumatic heart disease are also significant. Needless to say, there's a significant loss of health, productivity, health system costs, particularly when you're dealing in settings where there is no universal healthcare or baseline coverage. And I think we can all agree that despite political commitments from these UN high-level meetings, including the one that's upcoming, the implementation of policies to combat non-communicable diseases, particularly cardiovascular disease, remains inadequate. Now, the issue with cardiovascular disease, and I think these next 2 slides probably summarize a little bit of why I ended up in cardiology. The issue with cardiovascular disease is that we actually know what to do. So this slide, as you can see, is showing us cardiovascular disease mortality in the US from 1950 to 2015. And I'll have you look at 1950. This was around the time, I believe, Eisenhower had his heart attack. We had, nothing available. You sat in the ward for several weeks and you just sort of went on vibes and hoped for the best. And you can see a significant bending in that curve to 2015 and even lower when we look 10 years down the line. This slide, apologies, is from Eugene Brunwald and Betsy Nabels in the New England Journal. I may have lost the reference here. Is one of my favorites. Looks very much like the slide that we're looking at here. And what it does is that it superimposes all the significant cardiovascular innovations over time. And if you see at the bottom here, I kind of helped them out a little bit because they stopped in 2010. So I extended it, showing TAVRs, GDMT, PCSK9s, lots of other innovations, a little bit of a tick up in cardiovascular deaths since COVID. And that's something that we saw across the board, given the disruption in COVID. But I think what you can appreciate in this curve is that in cardiology, there are very significant things that we know and we have done, and they work, they're effective, and they can bend the curve in terms of cardiovascular mortality. In essence, treatment, and this graph here is showing you an association between treatment scores and change in cardiovascular disease mortality. So on the x-axis is the treatment score. The higher the treatment score, the better. And on the y-axis is cardiovascular mortality. So in essence, treatment, we know, and this sounds like it's common knowledge, but it does save lives, particularly in cardiovascular disease, and given all of the innovations that we have. In fact, if you look at the potential cumulative impact of just 4 simple treatments, it's not our fancy stuff. It's not the ARBs or SGLT2s or GLP1s or PCSK9s. No, not our fancy stuff, just the basic stuff. If you look at the potential cumulative effect of aspirin, beta blockers, lipid lowering, ACE inhibitors, you could have a cumulative benefit in excess of 75% of relative risk reduction. Again, it's just our basic stuff. We've not even sort of hit our fancy things and our blockbusters. So in essence, when you look at, sort of those mortality declines that I showed you in terms of cardiovascular disease, I think about 50% of those mortality declines are probably due to improved clinical care, with another 50% kind of being due to overall improvement in risk factors, like, lower smoking, improved diet, although some of that, particularly in the US, has been counteracted by increase in obesity and increases in diabetes. So essentially, by doing improved prevention and management of risk factors, improving access to acute and chronic treatment, not just for acute coronary syndromes, but really for established cardiovascular disease overall, and determining a kind of robust system for clinical monitoring and surveillance, you can strengthen overall clinical care and contribute to these declines in cardiovascular disease deaths. But in spite of everything that I've shown you, and particularly in spite of the fact that we know that just the use of basic medications in secondary prevention, right? These are in people who are at the very highest risk. They've had a prior heart attack, they've had a prior stroke. This is incontrovertible in terms of a method for reducing overall cardiovascular disease burden. So in spite of what we know, there has been no change in the use of secondary prevention medications from 2011 to 2021. This is just a hot off the press study from Jack. Actually just came out yesterday. I was honored to edit this particular paper. And this is looking at the PURE study. And they went back and looked at their analysis from 2011 and a follow-on analysis in 2021. And if you look at the bottom column here, in the blue, we're looking at high-income countries, and from baseline, use of secondary prevention medications at 88.8%. So I note that even in our hands, we're not at 100%. There was some decay in that use over time to 77.3%. But the situation looks very different when you look at low-income countries in the bottom panel here in the red. Baseline use is 20.8%. And there's a slight increase to to 27.5% by visit 5. But what is not shown in these numbers is that the bulk of this, based on their definition, the bulk of the low-income country use is actually coming from India, which is a little bit of an interesting case because they have access to generic medications and have a little bit better availability of medications than most countries do. If you take India out of this equation in low-income countries, then actual baseline use is about 6 to 8%. And that worsened over time when you looked in 2021. So again, we're just talking about secondary prevention, aspirin, beta blockers, statins, maybe an ACE inhibitor in people who are at the highest use. And we see that uptake or use of these really very cheap medications in low-income countries in the highest risk patients is about 6%. So what is the reason for this? And this slide breaks down what I was talking about a little bit earlier. There's very limited availability of medications, not in our hands. In high-income countries, there's good availability in urban and rural areas. But when you're looking in low-income countries, except India, then you see that there's only in 36% of urban communities and about 0% in rural communities. And as you can see, these numbers look very different when you're looking in India. Outside of availability, cost itself remains a major issue. So in high-income countries, our cost of these 4 drugs is negligible, right? You can get these as part of the, $10 Walmart prescriptions, and not to say that they're people for whom this isn't a challenge. But when you look in other places, then affordability of these 4 drugs is almost 50% of household income in a rural low-income country. And actually in India, in spite of availability, cost of these drugs is over or close to 70% of household income. So they're mostly not available, and even when they're available, too costly in most settings for a lot of people to afford. Moving on from the talking about secondary prevention, let's maybe pivot a little bit and talk about a different sort of heart disease, in particular rheumatic heart disease. Again, not something that we see often. I see a few patients in my clinic here, and these are patients who are either immigrants from other countries or older patients in their 70s and 80s who were born sometimes in rural communities who still have a small burden of rheumatic heart disease. But as you can see, countries in the yellow are endemic and countries in the blue are non-endemic. Still a significant burden in sub-Saharan Africa, in particular, in South Asia, in Southeast Asia, and a little bit of scattered burden not shown well here in Australia, particularly among the Aboriginal population. In 2018, the World Health Assembly passed a resolution on rheumatic fever and rheumatic heart disease calling for eradication. But again, this is something that has not found an incredible amount of traction in terms of its implementation. So to briefly summarize, we know that cardiovascular disease is largely preventable. There's a lot of cost-effective strategies that can address risk factors. We're not talking about that as much today, but there are also cost-effective strategies that can address hypertension, hyperlipidemia, diabetes, as well as effective treatments for many forms of cardiovascular disease. The gaps in cardiovascular disease outcome that we see between high and low income countries, high or low and middle income countries, are mostly related to an increased risk factor prevalence. I didn't talk about that as much. An absence of clinical treatment for risk factors or cardiovascular conditions, and really not enough research and action, particularly on neglected cardiovascular diseases. As I showed you, secondary prevention medications are unavailable, and if they're available, unaffordable for a large community proportion of communities and households. And there is a lack still of appropriate treatments for some endemic cardiovascular conditions, like rheumatic heart disease. So where does this leave us? I think for me, this first part of the talk and the things that we've gone through, I think are things that we all know. We talk about this a lot. Cardiovascular disease is endemic, is the number one cause of mortality. These are the reasons. But it's become really important to make a pivot, not just about listing, what all the issues are, but really trying to think about what are the ways in which we can take the knowledge of cardiovascular disease, what we know about how to prevent and treat cardiovascular disease, and apply it to what is, a significant problem now and has the potential to continue to be a major cause of mortality in the future if nothing different is done. To me, the key really lies in two things, and that's the topic of this talk. It lies in innovative strategies needed to close this gap. And having a strategy is not the end of it. You need a strategy, but you also need to implement that strategy. So in the next part of this talk, I'm going to pivot to talk about some, not all, some of what these innovative strategies are that we can need to think about in terms of trying to close these gaps in cardiovascular disease. So one is, really thinking about innovations in cardiovascular risk factor management. The Heart's technical package was, something that I was privileged to work on or develop when I was at WHO. They were kind enough or unassuming enough to ask me to, think about, give me a little bit carte blanche. If you had to think about this problem, what would you do? And to me, the key in addressing cardiovascular disease risk factors really lies in having innovation or interventions at the primary healthcare center. The way that we work, here in the US and other high-income countries, you have cardiologists, you have primary care providers, and there's some of that risk management happens, or most of it happens with PCPs, but we also get some of it at the level of cardiologists. But interventions at primary healthcare center really should constitute the front line for chronic care delivery, right? They can be patient-centered. It's more accessible for long-term care. It's community-based, and you can have a sustainable system that is not dependent on building out, these major dependence on having a specialist or cardiologist or anybody else who's managing these risk factors. If you think about, what the core issues are, which is that there's limited, if any, management of cardiovascular disease risk factors at primary healthcare center, many of these health systems are weak with very little operational guidance. There's a lack of access to essential medicines, technology, trained healthcare workers. Putting all of those things together, we thought that it would be really important to prioritize and implement a core set of interventions to strengthen and scale up cardiovascular disease management at the primary healthcare center. And that's how the Hearts package was born, really looking at 6 key elements: healthy lifestyle, evidence-based treatment protocols, access to essential medicines and technology, risk-based management, team care and task sharing and task shifting, as well as having a robust system for monitoring, patient data collection, and program evaluation. So, we really thought that if you take these innovations in simplifying treatment with standard risk-based treatment protocols and a core set of medicines and technology, and you take innovations or improvement in the service delivery cascade with improving access to medicines and technology and task shifting and clinical monitoring and surveillance, then you can simplify, you can standardize, and all of this can go to support a significant scale up of your cardiovascular disease management approach. And for those of you, who are in the ID world or HIV world, you will understand this. This is almost a direct crib of the public health approach to HIV management, because that works so well. And when you think about cardiovascular disease, which is also a chronic disease, then I think some of these, tenets or innovations, can work as well. So In the time since we developed the HEARTS package and up until, I think the slide is from 2022, package has actually been implemented, quite widely. At the last count, in 5 years of implementing the package, there were over 32 countries that have been enrolled, a lot of them in South America, few countries in Africa, India and China, and over, at the last count, 12 million patients enrolled, 165,000 facilities activated, and about 40% of patients with blood pressure control, compared to a baseline, I think that was in the teens or 20s. So thinking about, the HEARTS program and that particular innovation, what it does suggest is that implementation of blood pressure control and management of cardiovascular risk factors at scale is feasible. Since 2017, when we developed this program, the HEARTS package has actually delivered a standard hypertension control package in a number of countries. Like I said, 12 million hypertensive patients treated across 32 countries. And the success of this program does demonstrate that this kind of approach can be scaled and sustained in LMICs with government leadership and support. What are other innovative strategies that you can think about in terms of closing these gaps? We can improve treatment, right? So we can improve the system, which is what the HEARTS technical package is doing, but you can also improve our actual treatments, again, in a very patient-focused way. Polypills or fixed dose combinations, if you want to be formal about it, in cardiovascular disease, are usually some combination of an antihypertensive, a statin, and an antiplatelet. And a lot of the studies have compared the fixed dose combination against our single individual pills, which is our usual care and our usual approach. A lot of the studies, this particular study from Jose Castellano and co in the New England Journal, was looking at a polypill strategy in secondary prevention. Remember, I showed you those slides a little bit earlier about the very abysmal uptake of secondary prevention, particularly in low and middle income countries. So a polypill strategy, which they tested, significantly lowered outcomes and improved adherence. So if you looked at the primary outcome of cardiovascular death, non-fatal MI, non-fatal stroke, there was a significant improvement in the polypill group, 9.5% of patients versus usual care. And some of this is probably due to an improved medication adherence as reported by patients in the polypill group at 6 months, and actually persisting when you looked at that group out to 24 months. So they concluded that in this population, mostly older adults, recent MIs, that treatment with a polypill for secondary prevention resulted in a significantly lower risk of MACE as compared to usual care. The study by Munoz et al. Looks at the polypill actually even within the US. So I think the Castellano study was a global study, but even within the US, a polypill or fixed dose combination was quite effective in an underserved US population. So top line is our usual care group. We do what we do. We give them a separate aspirin and a statin and a beta blocker and an ACE inhibitor. And you could see reductions in systolic blood pressure in the polypill group, as well as significant reductions in LDL cholesterol, again, in the polypill group as compared to usual care. So fixed dose combinations, particularly in low resource settings, do some really important things. They can offer a very simplified treatment regimen, right? And you can think of this in the hands of, say, a community health worker who's seeing high-risk patients or patients with prior MI or stroke. It's sort of a very simple treatment regimen. It streamlines the supply chain and all the associated costs, right? You're now not looking at a supply chain for 4 separate medications, but for one medication. You can improve compliance, as we saw, and reduce treatment interruptions, and it can fill a critical role in addressing those gaps that we saw in secondary prevention post-MI and post-stroke. Other innovative strategies that I think are critical is making sure that we have targeted research and strategies that are relevant to low and middle income countries. So the Invictus study, which was actually pushed by the Pan-African Society of Cardiology and Bongani Mayosi, was looking at DOAC, rivaroxaban, versus warfarin in valvular AFib, right? So when you look at all of the studies in atrial fibrillation, what group of people do they exclude? They exclude people with valvular AFib. What group of patients tend to have valvular AFib? A lot of our rheumatic patients who have rheumatic mitral stenosis end up with valvular AFib, and this is the exact group who were not studied when the studies of the DOACs were done. So the Invictus study, looked at rivaroxaban versus vitamin K agonist in valvular AFib. Unfortunately, that study did not show any significant or superiority for rivaroxaban, and actually improvement for the vitamin K agonist. So, based on this study, but it answered a really critical question, in a population that is not often seen in our hands, but, allowed them to sort of move forward to understand the best sort of management for these patients. And this is Professor Mayosi, who led the Invictus study. Finally, there's no talk that is complete without talking about technological innovations and digital health and AI. But in a serious way, the digital healthcare transformation, it's another important innovation that can be leveraged in terms of addressing the cardiovascular disease burden. Machine learning and AI with simple inputs like the ECGs, which is being done very widely. Another application that we've been using in our hands is some of the AI tools that help you in terms of doing the screening scans for rheumatic heart disease. They can improve risk prediction for atrial fibrillation, LV dysfunction, and they can allow for better resource allocation. And it is critical, obviously, to consider the implementation of these technologies, particularly when they are developed. But just to say that there is a significant role, for some of these tools in terms of the innovations that we think about. So essentially, we've talked about the burden of cardiovascular disease. I've highlighted some of the key gaps in the cardiovascular disease burden. I think I've tried to convince you that by showing you some examples that we need innovative strategies to close those gaps. But having the strategy, like I mentioned earlier, is not enough. We need to think about ways in which we can implement these strategies, and really implementation science is key to optimizing these innovations and to actually closing these gaps. So in the final part of this talk, rather than, give you a talk about implementation science, I thought I would show you, a little bit of what we have been doing and how that implementation looks like in our hands. So under the auspices of the MGH Global Cardiovascular Health Program, we've been working in several places, but a lot of one of our major sites and collaborations is in Cabo Verde. Cape Verde, if you don't know Cabo Verde, as they're officially called, is an archipelago off the west coast of Africa. So it's right here, pretty close to Senegal and to Dakar. In Cape Verde, the number one cause of mortality is cardiovascular disease, largely driven by strokes from hypertension, atrial fibrillation, rheumatic AF or valvular AF. And the burden of cardiovascular disease still reflects a society that is very much in transition. So they do have coronary artery disease, they have strokes, but they also have concurrently a significant burden of rheumatic heart disease. They're very basic cardiovascular services in their referral hospitals. There are only 11 cardiologists in the country, 5 of them in the public system and 6 in private hospitals. So I thought it was illustrative, maybe to take you through, a case presentation, so you have a little bit of a sense of what we saw, when we first got to Cape Verde last year. So this is a case that Doreen De Faria, who's not here today, but someone that is a key part of this program, saw when she was a 19-year-old who presented with dyspnea and tachycardia in Fogo, which is one of the smaller islands. They initiated immediately when she presented an inter-island transfer to the main teaching hospital, the Hospital Agostino Neto, where she was seen with pulmonary edema. Echo diagnosis, obviously there's no cardiovascular services in the smaller islands. At that point was of severe rheumatic mitral stenosis, AFib, pulmonary hypertension in this 19-year-old at 32 weeks gestation. So she was placed on the list for urgent evacuation to Lisbon because in Cape Verde, there is no capacity for any advanced cardiac diagnosis or treatment. They still very much depend on sending urgent cases to Lisbon. Of note, Cape Verde was a former colony of Portugal, so they maintain sort of those ties with Portugal and with Lisbon. Unfortunately, she deteriorated en route, and by the time she arrived in Lisbon and was planned for urgent cardiac surgery, it was a little too late, and the mother and the baby passed during the intervention. This case, as illustrative and sad as it is, I think is one that kind of, in all the different parts of the presentation are relevant to some of the work that we've been doing in Cape Verde. How did this 19-year-old, with rheumatic heart disease, go undiagnosed until 32 weeks of gestation? What were the delays in terms of, obtaining care, obtaining a diagnosis, and getting her to the point, where she could get care in a timely way, and what are the delays and what was needed, to make sure that we didn't arrive at this outcome. To give you a little bit more detail in terms of what cardiovascular disease looks like in Cape Verde, like I mentioned, the largest cause of death is circulatory diseases. And in terms of risk factors, hypertension is still a major risk factor. And as we mentioned, rheumatic heart disease is also pretty significant in Cape Verde. I already talked to you about the human resources, of which there isn't very many. I will note that they have one echocardiogram, actually two in the public health system, one in each of the referral hospitals. And then, there's a lot of systemic challenges, as we saw with that case, significant overdependence on evacuating patients to Portugal, inadequate public education around cardiovascular disease, a lack of prioritization, and then this issue of the double burden of cardiometabolic disease as well as rheumatic heart disease. So when we first arrived, we worked with their local cardiologists to prioritize what they thought were the key issues that were needed, including the development of a rheumatic screening program, community education, a PACER program, because they had a lot of patients waiting for pacemakers and many dying of complete heart block as they had no temporary wires or pacers, and then working with them to build a comprehensive program at primary healthcare for managing cardiovascular risk factors. If you'll just give me 1 second, I'll plug in my computer. So just some key milestones, in our partnership in Cape Verde. We initially engaged with them. We've had several visits over there. We've had a primary local partner, who is Dr. Diaz, the head of cardiology, visit us here at MGH. And we've had other sort of government officials, including the Minister of Health, also here at MGH, really working with them closely in developing a program of work that reflects their needs and their priorities. So ongoing work, we started a rheumatic heart disease screening program and echo training for some of their sonographers there. In June of last year, we worked with them on a pacemaker implantation program with the Boston Cardiac Foundation and training of local cardiologists. And on our return visit in April of this year, we're expanding the rheumatic heart disease screening program, as well as working with them on a pilot study for implementation of the HEARTS package in their primary healthcare centers. So, and I'll just try to end quickly here so we have, time for questions. So our end game for rheumatic heart disease in Cape Verde really is ending RHD. It's not managing it, it's really making it go away. And what we plan is to extend echo screening, increase the availability of their echo machines, teaching their non-physician health workers how to expand echoes, how to obtain echoes. And this is with the help of AI-guided teaching, and helping them develop a national cloud-based rheumatic heart disease registry, updating their guidelines, and also developing a research pathway on the national implementation. These are just some pictures of our MGH electrophysiologists working with the local group in Cape Verde in the pacemaker implementation. So, just one quick word on the MGH Global Cardiovascular Health Program, which is the platform through which we've done a lot of this work. It really just is based on achieving global health equity in cardiovascular disease through implementation at the local level. We believe that catalyzing clinical infrastructure building, building a collaborative implementation research portfolio, education and training, as well as local and global advocacy are really the key ways in which we can work with our partners in closing some of these gaps. We have a robust faculty engagement, and this serves also as my thank you to Doreen and Carl and Shana and all the people who've been, really key in terms of faculty in this program. And also thanks for the support from the Harvard Global Health Institute, from Louise, and and everybody else who has really been involved in this work. So just to end, in September 2025, the UN will hold this 5th high-level meeting on non-communicable diseases. They will consider all the progress, but there are some critical actions that need to be taken in order to advance control of cardiovascular disease. One is that we need to absolutely expand universal healthcare for cardiovascular disease, yes, for other conditions, but this is critical. Without addressing this, particularly at primary healthcare, then it becomes impossible to make some of the gains that we need to make. Full implementation of a package like the HEARTS package in primary healthcare is critical because it starts building a standardized framework for managing cardiovascular disease. Access to cardiovascular risk assessment, which also goes along with the HEARTS package, is critical. And number 4, having access to safe, effective, and quality assured diagnostics, medications, treatments, and technologies is critical. You can see patients, you can diagnose, but if you don't have a way of treating them, then you're not really making any progress. And then finally, I think the full implementation of the prior resolution on rheumatic fever and rheumatic heart disease is also important, because as we see, there continues to be a major burden of rheumatic heart disease, and this is almost entirely in low and middle income countries. And if we're trying to close those gaps, then it will be critical to address this. So I just want to thank you all for having me again and giving me a chance to talk about some of this work. This picture is from a mural in Praia, which is the capital of Cape Verde. So I will stop there, and I'll be very happy to take questions.
Thank you so much, Dr. Onuma. That was really a tour de force. You covered a lot of ground on this really, really broad topic and showed some innovative work and a special connection that your team has in Capo Verde. So thank you for this great talk. While we wait for people to, we invite all the participants to put in questions either through the chat or through the Q&A entry. I have a couple of questions I was hoping to ask. Based on your experience and insights into building up global cardiovascular programs, one thing that I've noticed overseas is how difficult and challenging it is to manage diabetes in many low and middle income countries. And this is certainly going to be related to burden of cardiovascular disease. Do you see sort of a ceiling set on how much cardiovascular disease can be addressed based on diabetes care in some settings, because as you know, access to insulin and even in some places diagnostics is so limited it's almost non-existent, and diabetes ends up posing such a big burden on the health system. So how do you see strengthening diabetes care in the effort to address cardiovascular health?
Yeah, I mean, I think that that's a really good question, and the answer really is that they have to go hand in hand, right? You know, the time for building all of these sort of individual vertical programs is really, that doesn't work, especially when you think about what is the interplay, as you've nicely mentioned, between diabetes and cardiovascular risk. So I think the answer is, still goes back to universal healthcare, right? It provides a basic platform in which you can, yes, address cardiovascular risk, including the risk from diabetes, and do this in a sort of integrated platform. So that's what we've been, not a separate, this is your hypertension or cardiovascular program. Now this is your diabetes program. Now this is, your HIV program. But I think it's, kind of understanding that interrelatedness, and hence that kind of that focus on looking at cardiovascular risk, as opposed to just kind of picking out individual factors. Risk approach then sort of pulls in necessarily the management of diabetes, which obviously if you find and treat patients at an earlier time point, then maybe you can forestall some of those events downstream.
That's very well said. We have a couple of questions in the chat. Dr. Esther Freeman says, amazing. Can you please share some insights in how you fund this work?
Esther, that's a great question. As always, and particularly with sort of the changes that we're all seeing around us, funding remains something that is a critical part of this work. But I tell you something that has been a key tenet of how we work. For instance, our work in Cape Verde, you hear me use the word catalytic. We see that not as, showing up to build out a program or, build out the clinic, but, really sort of working with partners who are at a point, like when we got there, we've worked very closely with the university, we've worked closely with the government. We understand that this is something that is in their priority. They have this as a key priority of what they want to do. In Cabo Verde, they are spending about 13% of GDP on healthcare. But there has been a little bit, like I was mentioning earlier, a little bit of a mismatch on, their burden and what it is that they're actually doing. So a lot of our support, has been that very targeted, catalytic support, through a combination of things, some institutional funding, some grant funding, right? So using some of our research mechanisms also as ways of building capacity and building infrastructure. But we've also been clear, particularly in the conversations with the government, that this is something that will involve a significant commitment. So we can work with you on doing the pilot studies for rheumatic heart disease screening, but when it's time to scale up, then that's absolutely something that is in the purview of the Ministry of Health, and not something that we can bring and sort of scale up throughout. So it remains, I think, a major challenge. We don't have the Global Fund, we don't have PEPFAR, even though, again, those things are changing quite rapidly under our feet. But there's never been that sort of a mechanism for cardiovascular or non-communicable diseases. And that really obviously does hamper what you can do in terms of implementation. But even within those, I think that there are ways to advance the work, particularly if you consider your role very much in that sort of catalytic role, and making sure that you have all the right ingredients on the ground, even as you get involved with some of these partners.
It's an insightful response, and the way you've laid out the presentation, it also seems like the argument has never been stronger for prevention for some of these health systems, because because of the incredible amount of resources saved and life years that could be extended when they implement some of the kind of preventive programs or early diagnosis programs that you mentioned. Related to the funding, we have a question here from Dr. Jessica Haberer, who is asking something that I think is in all of our minds. Wonderful talk. In our current challenging geopolitical situation, where do you see support and leadership coming in for from global cardiology?
Yeah, Jessica, I think that that's a great question. Again, as we are all sort of navigating what is a changing situation, a lot of us really have looked at this, upcoming meeting again for what it is, as really as a way of reiterating some of these key points, that I tried to share, which is, we cannot afford inaction, right? It's not even like you can't afford action. You cannot afford inaction. And while, having sort of a global consensus and writing all of these resolutions and doing all of these things are important, I think that the leadership is really going to come almost from hand-to-hand combat, quite honestly, in countries, being able to show. And usually a lot of these conversations are not even with the health minister. They don't have the sort of power that you need. You need to be able to show sort of in real time, what that economic damage looks like. You need to be able to show in real time that, if you make a small investment, a couple of cents a day, say in treating secondary prevention, these are the sorts of gains that it buys you down the line. I mean, we're lucky to some extent that, some of these treatments, some of these management is not, these are not things that can significantly expensive. You can make a sort of a cost benefit argument for it. And that's what a lot of people are doing. So in the absence of a central, what we can expect to be an absence of central US leadership around this issue. And to be fair, even in good times, I don't know that we had strong US leadership, around cardiovascular disease and other non-communicable diseases. I think that, we essentially democratize this process, making sure that we're talking directly and particularly to countries that have the most burden, that have the most involvement, and trying to get them to step up into the gap. I have to say, we found, with this particular approach, significant success. For instance, in a lot of the South American countries, where there's been significant involvement, Brazil, Argentina, Chile, everybody seems, even in the Caribbean, everybody seems to be really on board with this being, their critical or main health problem, and really stepping up in order to provide that leadership. So I don't have a crystal ball, and we were already not in a great position. I would expect that position will worsen over the next few years, but perhaps it's an opportunity to sort of democratize, if you will, this issue, and really take the case to countries in particular, and show them in a real way what the cost is.
Let me ask a question on that point you just raised. Why do you think there's been an emphasis or an approach from countries in Latin America? Has it just been the kind of state of the economies? Has it been kind of other aspects about the burden of disease in those countries?
Yeah, so I think it's both. I think that there's been a better recognition of what the actual, change in the burden of disease is, right? And you can't have that recognition, speaking to my earlier point, if you don't have data, if you don't have anything that's sort of, showing you what the situation looks like in your country. So I think there's been a real recognition in a lot of Latin American countries that the biggest burden is now coming from non-communicable diseases, and particularly from cardiovascular disease, and hence kind of a larger emphasis on trying to strengthen that aspect of their health system. And obviously a number of these countries are also middle income, or, upper low income. And then that does allow a little bit more of investment in the health system than what you would get.
Yeah, that makes sense. And the hope is that other regions around the world follow very soon, because once you're empowered to invest those resources, then I think it creates health for the working age population, for the aging population, and as you even pointed out with rheumatic heart disease for young populations as well. Maybe we can have this last question from Lindsay Martin, who says, how do you see an expanding nursing scope of practice globally as a means to address cardiovascular disease?
Yeah. So, Lindsay, I see that as being a critical aspect to addressing cardiovascular disease. Again, I didn't talk about every single innovation, but I think the innovation really of, task shifting or task sharing is something that is critical. In Cape Verde, with your 5 cardiologists for a population of 300,000 people, this isn't how you're going to close the gaps. You're going to close the gaps, when people are empowered, obviously, to practice at the top of their license. You don't need a cardiologist managing blood pressure or treating cholesterol or basic management for diabetes or other risk factors. This can be done as protocoled care and, be done by nurses or even nurses supervising non-physician health workers. So I think that this is absolutely critical in expanding the cardiovascular disease care worldwide. And I think I didn't talk about it as one of the innovations, but I think this is absolutely one of the key innovations. It's not in finding more cardiologists, is in using resources that are already available on ground to expand the scope of what people are doing. There's a lot of nurses doing maternal and childcare, for instance. They go into the homes, they're, seeing these women, but, the scope of practice is not extending beyond, maternal childcare, even though, a number of the people you see in the homes, either the moms or their husbands or their parents who live in the same home, have a big burden of cardiovascular risk factors.
That's great, and I think it also addresses the point simultaneously that brought up by Maureen Achebe in the Q&A, saying how do you scale up the progress that you described in Capo Verde? And I think that's exactly it. You empower the whole healthcare team to work on these important issues.
Yeah. And Maureen, I think that's a great question, and that's a great point. I see Cape Verde really as a solvable problem. Yeah, your name sounds like you're from Nigeria. That's the size of like a town, in Nigeria. It's the size of a neighborhood in Lagos. But if you can figure out, how you can solve on that level, then those are lessons and things that you can apply even in bigger contexts. Every place, whether you are even in a place like Nigeria, you can either be working in a state or part of a state, but starting off in a smaller context and in the smaller countries, really giving us a chance, to understand what works well, and more importantly, how can you come to scale? And once you learn those, not just, how do we do lots of pilot projects, but how do we come to scale? We hope that those are lessons that we can transfer, obviously, with some adaptation in other settings that have similar problems or similar issues.
Well, thank you once again. This was a truly excellent talk, and congratulations on the impressive work that you've built so far. I know that this is only work that's going to be growing in its importance and reach, and so I am sure we'll have you back to give us updates in the future. With that, we'll conclude this session of our combined global health grand rounds. I thank again Dr. Onuma for this excellent talk and for all of our participants who attended. We'll see you all next month. Thank you, everybody.